Metro team. I am newer to the team, but just last week we had another new senior program manager start. So I know I'm not the newest, and happy to be here. And let's see, then we,
Yeah, so this is a two-part training. So we have our session today, and we'll go over kind of like the supportive housing basics and all of kind of the fundamentals of supportive housing. And then on Thursday at the same time, same Zoom place, we will go through accessing supportive housing and the coordinated assessment and placement system in New York City. Next slide. So we've got three kind of like main learning objectives that we hope you'll all walk away with today. Again, learning the supportive housing basics, learning about the benefits of supportive housing, and then learning a little bit about supportive housing models, particularly for justice impacted populations. Next slide. All right, so I tried to be fancy, and I guess it's not fancy anymore, right? Everybody is like very tech savvy and Zoom savvy now. I tried to set up a poll, but it is not working. So we wanted to get a little bit of a sense of who's in the room and what you all know about supportive housing. So instead of making a selection on a poll, if folks could just kind of populate into the chat, how familiar are you with supportive housing? You know, kind of not much, don't know much about supportive housing, know a bit, looking to learn more through this webinar, feeling like you know about supportive housing, but are curious about how that can impact folks that are, or support folks that are impacted by the criminal legal system. You could be an expert, you could, you know, work in a supportive housing agency and feel like you know a ton, or something else. So if you wouldn't mind just populating in the chat and letting us know kind of where you fall in the spectrum.
So can I answer that question? Can I start?
Absolutely.
So my name is Denzel Jordan. I'm a KSAC counselor over here at Basics Residential. And I don't know much about supportive housing, but I do know that it's important for the clients when they complete the program. We don't want them to leave the same way they came in, and most of them come, let's say, for example, without having a place to stay and what have you. So I think it's imperative, it's very important that, you know, we do have more access to housing, potential housing, where we can, you know, place them, because that seems to be a very important issue for them. They're having technical difficulties, having a hard time finding housing. And I can understand why, because we live in the New York area, and housing, apartments, rooms, and stuff like that are very, very hard to come by. So I would like to know more about how can I support them in their efforts to potentially, you know, obtain a place to live.
Thank you so much, and thanks for getting us kind of like started off with the chat this morning. It seems like in the chat we've got folks like a real spectrum, folks that feel like they know quite a bit about supportive housing, folks that want to learn more, folks that know very little. And that's actually fantastic. I think that will really lead to like a pretty robust conversation with us today. So thank you all for joining in on that. Next slide. Alrighty, so a little bit about what we are going to cover today. Like I mentioned, we'll go through the supportive housing basics, the benefits of supportive housing for justice impacted populations. We'll talk about where supportive housing is in New York City, and talk a little bit about adding more supportive housing to our community, because one thing that we've found is that, you know, we know that supportive housing is really effective, especially for specific populations, and often the supply is not able to meet the demand. So we'll talk about how we can bring in more supportive housing to our community. And now I'm going to hand it off to Emma.
okay, here we are. So the first section, as mentioned, is the supportive housing basics. And we wanted to start off with giving the continuum, the scope of what New York City housing looks like. And this continuum spans from the most basic, the first step of emergency shelter and safe havens, and goes through all of them up until market rate housing, where someone wouldn't need services or assistance with rent. And so in between those spectrums, we also have temporary mock J hotels. We have someone. Okay, someone's in the waiting room as myself. Interesting. And then also we have transitional housing programs, which are temporary housing program models as well. We have listed here affordable housing, which also includes supportive housing. That is kind of like a branch of affordable housing. And we have public housing family reentry programs, which again, these are all kind of different models, different ways that they provide leasing and support if they provide support. And then, except the last one is the other end of the spectrum, which is what is in the orbit for market rate housing without support or leasing support. And we will be talking a lot about number 4, of course. So affordable housing is considered affordable because it costs 30% or less for the tenant. So the tenant's household income that they contribute is 30% or less. And then affordable housing can look like many things. It can look like a physical apartment. It could be a voucher that later gets you a physical apartment. And it also includes supportive housing. Affordable housing is a permanent housing that includes support with the lease, and the tenant is on the lease, but they are only contributing part of that lease. So it's more affordable to them and based on their need. And then lastly, income guidelines may vary for these programs. Affordable housing looks different depending on what city we're in geographically, depending on if it's all federal funded affordable housing, or New York City also has New York City funded affordable housing. And so, yeah, guidelines can vary, and typically a renter cannot earn more than the area median income, the AMI, which is set by the U.S. Department of Housing and Urban Development, HUD. And so we are supportive housing. We're talking about supportive housing mostly, which is a branch of affordable housing. And it combines affordable housing, so lease support, with services that help people who face the most complex challenges to live with stability, autonomy, and dignity. This intervention is not time limited. So like affordable housing, it is permanent. So oftentimes we'll hear the acronym SH for supportive housing, but some people also say PSH, which is permanent supportive housing. And you don't necessarily have to put the P there because it's kind of implicit that it's permanent supportive housing, because that's just part of the model, but some folks do say PSH. And so below we have this little graphic that says permanent affordable housing plus individualized wraparound services equals supportive housing. And what also is great about supportive housing is that the services for the tenant is based on the tenant. And that's what we mean by individualized. If there may be someone who has some mental health needs or medication that they would be taking, and maybe counselors to support about that, or it could be someone who has a substance use situation, and that the counselor is helping them with that. And so it's very unique based on the individual. And then I will pass it back to Lauren.
So I have a question, if I may.
Of course.
So one of the problems that I encounter with the patients, they apply for 2010E and they are given the voucher. But the problem is that even though they have it, they're having a hard time getting a place to stay. Why is that, may I ask?
Yeah, we're seeing that kind of all throughout the city, and then really honestly all over the country. There's not enough housing supply. In our session on Thursday, we will go a little bit more into access and how to, how to access supportive housing, and then also how to navigate the super complicated housing system to actually assist folks with locating housing that they can use, their vouchers for. There's a number of reasons why folks might be experiencing difficulty with actually locating a unit. One of them, like I said, being that there really isn't a ton of supply. But also then we see, particularly for the population that's impacted by the criminal legal system, that there's discrimination. Even though protection's in place, there's still discrimination about for folks that have criminal legal histories. We also see that, landlords are not always abiding by, the letter of the law as they're supposed to, and they'll say that they don't take vouchers or they, can't house somebody. And without, if there's not that advocacy piece, it's really, really challenging for folks to push back and be able to obtain housing. But that's definitely something that we'll also go into a little bit more on Thursday as well, if you're able to make that session.
So before, I know, like you said, we'll be going into that on Thursday.
Yeah.
So the question, just one last, like the part B of that question is, when you have the 2010 e-voucher, isn't that advantageous to the landlord because he's getting paid directly or not? So that he doesn't have to worry about his, right? So that would be a plus to have.
That's actually like a fantastic selling with supportive housing, is that, folks they have these vouchers and the landlords are guaranteed payment, at least for the portion that the subsidy is covering, right?
Right.
And then in addition to that, folks that are in supportive housing also have the added support of a case manager or a team that's able to support them. And those are, really big selling points for landlords as well, helping landlords understand what the program is and what the advantages are. Right. Yeah, and we're also, this won't be launched until the fall, but Emma and I are working with Enterprise, which is another, it's an affordable housing agency or organization, on a landlord training series so that we can provide education for landlords on the benefits of housing folks in supportive housing, the benefits of housing this population, and working to kind of debunk some of the myths that are often following folks with criminal legal histories.
Okay, thank you very much for sharing.
Yeah, no, thanks for asking. So some of the key components of quality supportive housing that we are going to go through are listed here. It's real important that when we are talking about supportive housing, folks are following a housing first model. And that kind of gets to the question that was just asked, where true housing first means that we are really screening people in and not screening people out. We're meeting folks where they are, and we are helping them get housing because it's a basic human right, not like a reward for clinical success or avoiding having any sort of like criminal legal history or background. But really that it's a basic human right. And, it's kind of in the name with housing first that folks need safe, affordable places to live before they're able to tackle any of the other root causes that may have led to their homelessness in the first place. So we also target households with multiple barriers. So supportive housing is really designed to help the most vulnerable folks in our community. So we do have certain eligibility criteria and targeting that we do, since there is such a lack of supply, to make sure that the folks going into the units that we do have available are the most in need in our community. Supportive housing should always be affordable. We often say that you cannot have supportive housing without affordable housing. So while they do differ a bit, you can't have supportive housing if it's not affordable. Like Emma mentioned earlier, tenants are on the lease. So folks do have their own lease. In some situations, there's master leasing situation or setups. But for the most part, tenants are on a lease and they're able to, be the leaseholder, and the supports that are provided really help them kind of embrace that and understand what it means to be a leaseholder. As oftentimes, this is somebody's first own apartment or own home. We work to engage tenants in flexible and voluntary services. So housing is not contingent upon services. In supportive housing, individuals do have the opportunity to say that they don't want to engage in services. However, with active engagement and assertive outreach, the vast majority really do start to engage in services. It can take a minute and it can take a bit to kind of build up that relationship. And because the services are voluntary, they need to be highly individualized so that they're attractive to folks and folks understand that we are designing services uniquely for them and not kind of like this one size fits all, like this is what we want, everyone in supportive housing needs these, 3 to 5 things, but really, really individualized and targeted to that household's needs.
So I have another, I'm sorry, can I ask a question?
Absolutely.
Okay. Right. So this thoughts are coming into my mind, and as they come, because of my age, I like to ask it. Isn't there at one time I thought that when you're putting up housing, especially apartments over X amount, a percentage has to go towards the community for low income? Does that still exist or not? So,
depending on the housing development, yeah. There are some ordinances or laws in place that prevent super saturated supportive housing communities. So we don't want to see supportive housing become kind of like institutionalization, right? Or like an institutionalized setting and make it like completely othered or cut off from other housing options. So there is typically in most developments, there's a segment that is available just for affordable housing and then a segment that is available for the supportive housing community.
And the reason why I ask, because I'm sure that you know as well as I, wherever you look around, because we are in New York State, there are a lot of projects, there are a lot of construction taking place, there are a lot of buildings going up, before you know it. And so with that being said, since we have a lot of clients who are homeless, who need supportive housing after they complete the criteria, meet the policies and procedures of the program, they've done what they had to do, they raise their self-esteem, they get a job, they're saving their money. So with all these housing going up and taking place, I would think then that a percentage, maybe 5% or 10%, once you're putting up a structure in the community and it has, X amount of units, then a percentage of that should go towards the minor, you know what I mean? So this is where my mind was going with that.
Yeah, thank you. And then finally, the last item on here that we'll talk about in a little bit more depth in a moment is really connecting folks that we're working with community so that they don't feel isolated and kind of feel othered, and they can really embrace, being in a community, become embraced by the community, and feel like they are in a place that they belong. Next slide. So a little bit more about the key principles of housing first. We talked about it before, so I won't belabor it, but it should include, quick access to housing, which is not always the case, right? Especially in New York City. So it takes longer than we would like to see, right? But it's the intent is to get folks into housing as quickly as possible, which is not always as quickly as we'd like to see, but trying to get folks in as quickly as possible. We talked about that fact that we're targeting kind of the most vulnerable folks in our community, that people are, their own lease holders. So they do have both obligations and protections as a tenant. To the highest degree, we want things to be centered on client choice. And that really comes into play when we're talking about services, especially. And we also just want to recognize that client choice is not always something that is highly available when we're placing folks into units, right? It often kind of depends on what unit is available for folks. And there's not, unfortunately, not always a ton of choice with where folks get to be housed. Of course, they can, pass on units and provide input on where they would like to be. But where we can really center on client choice is when we're engaging in services. Noting again, assertive engagement. So that means that we are not, kind of like sitting in our offices waiting for folks to come to us, but rather we are actively being out in the community, kind of trying to meet folks where they are, to engage them, not to force ourselves, down their throats, but
Right.
to
Mhm.
remind them that we are available and we are there to provide an array of services that we can hopefully engage them in. Again, noting that tenancy is really not dependent on participating in services. And then finally, just noting that, we need to embrace a harm reduction approach. Again, that, tenancy is not a reward for clinical success. It's not a reward for being sober. But when we do get folks into housing, we want to take a harm reduction approach so that we can work with them at a pace that they're comfortable with to incrementally reduce the risk of potentially harmful behaviors that they might be engaging in.
Okay, and then also part of a key component of supportive housing is that it targets households with multiple barriers. So it's not looking for just one or two criterias, but it's definitely okay and encouraged and accepted that multiple barriers is what this program should be utilized for. So someone that is lacking housing, that is low income, and then faces a multitude of complex medical, mental health, substance use, et cetera, that are co-occurring, is what this model is targeted for. And there's other in the continuum graphic that I displayed and went over at the beginning. Those models have different eligibility criteria than supportive housing does. And this is the baseline for supportive housing. And also a key component is that the housing is affordable to the tenants, and that they are able to continue contributing their portion of it. So ideally that person pays no more than 30% of their income toward rent and utilities, and the rest would be covered. And their name is on the lease, which offers autonomy and independence, and just gives the tenant a bit more comfortability with their lease and with their home.
So, question, with that 30%, is there a time limit on the 30% that the tenant that they are paying? Is that cutoff criteria date or what have you? That's ongoing. So that's wonderful.
Yeah, so that
Yeah.
30% is ongoing and designed to be in place as long as the voucher is in place. So they should never pay more than 30% of their income.
Okay.
Now, when folks are able to secure employment, sometimes we'll see that 30% of their income becomes the rental amount, right? And that then they essentially are no longer in need of the voucher. And
Right.
typically the regulations stipulate that if someone is able to pay their full rental amount based on their income for
Right.
6 months or longer, then they do face then losing that subsidy. But there is a kind of, they'll give them that 6 months so that there is like a little bit of a cushion. But when somebody demonstrates that they're able to pay the full rental amount, then that voucher
It's
would
just taken away. Right. Understandable.
Lauren, will you talk a bit about if someone has disabilities though, like if they qualify for disability payment, that they wouldn't necessarily need to seek out job security,
Right.
but their disabilities could contribute to the 30% rent as well.
Okay.
Yeah,
So,
whatever their income is, 30% is what their tenant portion would be. So if they get, $700 a month, 30% of that would be their tenant
Yeah,
portion.
sure.
Mhm.
Understandable.
Yeah. Yep.
Passing it back to you.
Yeah. So we talked a bit about the fact that tenants in supportive housing do have a lease. So we try to provide as much housing unit choice as possible. And ideally folks would be, showed a number of different units and they would be able to choose which one suits their needs best. And we would also try to take things in place or into consideration, such as, if someone's got a disability, we're not going to show that, and they're in a wheelchair, we're not going to show them a 4-story walk up, right? So thinking about the tenant's needs and supporting them in the process of searching for a unit. The leases are identical to folks that are not in supportive housing. So we, want to support folks in being able to kind of achieve and maintain stability in their housing, and the services are designed to do that. But we're not trying to create an alternate reality for folks, right? So they do have a lease that's identical to anybody that's not in supportive housing. Tenants should have a real clear understanding about what their rights and responsibilities are. When I worked in supportive housing, our practice was to ensure that we, had a sheet with kind of FAQs and with targeted information on their rights as a tenant, but then also their responsibilities as a tenant. And as I mentioned earlier, this is often the first time that folks are coming in as leaseholders, and that transition into housing can be really, really challenging. I think when I first began in supportive housing a number of years ago, I had a super naive perception that like folks, when they came into housing, like everything was going to fall into place, right? And they were just going to like know what they needed to do, or not necessarily know what they needed to do, but like that it was going to be an easy transition because it was seemingly so much more desirable from, where they might be coming from if they were living outside the shelter. But it's actually quite a challenging transition. So it's really important that we're supporting folks right from the get-go and letting them know what's expected of them and what their rights are, right? There is a power dynamic that exists with landlords and leaseholders. So making sure that folks are aware of their rights is really important. And then finally, there should not be any service participation agreements. In some instances, I know that supportive housing agencies have had tenants sign a consent for services, which essentially would just allow case managers to continue to contact them and try and engage them in services. But they should not be signing any sort of like agreement saying that they, will, promise to meet with their case manager twice a month and, have their housing be contingent on that in any way. Just if I could just finish this one point, similarly, we would not ask anyone to sign any sort of agreement saying, that they promise they'll take their medication or that they promise that they will maintain sobriety and, never use or relapse. And, we really strive to prevent eviction. But it is also important to note that when it is necessary to evict a tenant, it should only be for a lease violation, such as, failure to pay rent. It should never be because they're not engaging in services or because they're not behaving in a way that, we would like to see them behave. If those behaviors are impacting their lease or violating their lease, that's another thing. But just to really drive home the point that we should not be putting stipulations on folks in a services arena that would impact, their tenancy.
I had a quick question.
Sure.
Yeah.
Who helps them? Is there an agency when you meet the criteria for supportive housing? Who helps them find these apartments, or is it up to the individual? That's what I was thinking.
Well, so there are housing navigators that should help assist with the location of units, and with there's a Homebase is a resource that's available to folks. Sorry, I just stumbled on my words for a moment. Homebase is a database that's available to folks that shows kind of like all available units that take vouchers. So you can kind of like start with that database, get an idea of where you would want to look for units, and then kind of go from there. But there is with certain vouchers and things like that, there's like housing navigation supports that are in place. Can you hear me? And typically it would be like a case manager working, whoever is, made the referral, working with the person to help them secure.
Can you hear me? Hello?
Yes, I can hear you.
Oh, okay. Yeah, I'm sorry. My name is William. I wrote down I was having some audio difficulties. How impactful are open felony charges on the opportunities for clients to obtain housing?
So the fact that somebody, has an open charge should not impact their ability to be in supportive housing. Frankly, any charge or criminal history should not exclude somebody from being able to obtain, be accepted into supportive housing. Sometimes, those charges specifically, like if somebody has a conviction for production of meth, they'll be barred from, various housing subsidies for life. And then that can get really challenging. Arson can be another thing that's really, really challenging to get folks housed, but that's more like on the landlord side, that they're not going to necessarily accept folks. Open felony charges, I'm assuming you're meaning like, that somebody's not been convicted of something.
Correct.
Should
this
not
is
impact their
drug
housing
court.
because they've not been convicted at that point.
Gotcha. Thank you.
Yeah, and I say shouldn't, right?
Right.
I say shouldn't. That doesn't always mean that that's the case, and that's what we're seeing.
Right.
But if we're really like working to embrace housing first, then that should not have an impact on somebody's ability to be in supportive housing. And I
Understood.
will say too, I have over the years, I have absolutely successfully housed folks that, have been incarcerated on murder charges, that have, done their time, and worked with folks that have open charges through various different, situations and kind of ways that can play out, and have had a lot of success with folks that have had what at face value might seem like really scary or challenging charges or something like that.
Thank you.
Yeah, thank you.
So I have I wanted to get some clarity on this no service participation agreement, where it was stated, if I'm not mistaken, what the most important criteria for the client to be, let's say, for his lease to be.
Would you mind speaking up, Denzel?
Sure. I think let me. Can you hear me now?
Yeah,
Yeah.
that's better.
Okay, so let me not move too much with this thing. So the main criteria is that if a person is negligent in paying his rent, then that is the main ground for being for the person losing the apartment or the place. You're saying then that they cannot participate in any agreements where if they're not taking the medication, they lose their apartment or stuff like this. But so I'm thinking, so you have the different mental health population. Some needs assistance. If they're not taking the medication, then it takes them on a different plateau. We know that some may engage regularly in because they have a place, may want to, we hope not, but they want to continue to use. So you're saying then that's not grounds for dismissal from the apartment only if they cannot pay rent? If they continue
No,
to use?
not saying that. No, sorry. Thanks for asking your question and giving me the opportunity to clarify. So I wouldn't, definitely not saying that the only reason that folks can be, evicted from an apartment is if they don't pay rent. But in the situation that you're describing, if we've got somebody who, has a diagnosis of schizophrenia and they've got really pervasive mental health symptoms when they are not taking their medication, right?
Exactly.
And yeah. So we can't mandate that somebody take their medication, and we can't force them to engage in mental health treatment. What we would do, though, is help try to build insight on how their behaviors, when they're not taking their medication, might impact their tenancy. So, for example, if they are screaming kind of like at all hours of the night and disrupting their neighbors, and maybe they're getting aggressive or harassing folks, that could turn into a situation where the landlord does have the right to evict them. And then we would have to work with them through that. But we wouldn't say, you have to take your medication to avoid, any sort of like potential situations that might arise if you don't, in order to maintain your housing. So then we would just work with folks to, like I kind of help build insight on how their behaviors are potentially impacting their tenancy. And then one thing that we've also done in supportive housing is come up with things, what we called it was like an eviction prevention program. So if we had a good relationship with the landlord and somebody was at risk of potentially losing their housing, we would enter into some sort of agreement where we, talked with the tenant, talked with the landlord about the behaviors we needed to see changed, what we could do. And that would be like in an effort to avoid the landlord filing eviction, right?
Understandable. Thank you very much for sharing.
Yeah, of course. Okay. Next slide, Emma. Thank you so much. Alrighty. So thinking about, flexible voluntary services and kind of expanding on that a little bit, services staff will use a variety of really proactive and oftentimes very creative strategies to try and engage folks in services, right? And those can be kind of on-site services, that can be one-on-one case management, or it can just be connecting folks to like community-based opportunities and things like that. I had a tenant who was really wary of engaging in any sort of like formal case management relationship. And I just started giving her a ride to the grocery store like a couple times a week. And, I waited for her to kind of like start the conversation, and eventually that developed into, us having more robust conversations, and eventually turned into more of a service relationship. Services staff should be educated on techniques to really like engage and link people in, and to help build insight and intrinsic motivation to help folks change their behaviors, or the behaviors that might lead to harm, or might lead to them losing their housing. Services are not time limited. And this is kind of where that like permanent piece comes in, right? So it's not like you've got, 3 years to get it together, otherwise you're out of our program.
Right.
Or you have services for, the first 9 months, and then we're going to like fall back and it's on to you to figure it out. But services should really be based on need. So oftentimes the most intensive services are, happening when the person's moving in, but then also understanding that throughout the duration of their tenancy, folks are likely going to kind of like dip in and out of services and have periods where they're more self-sufficient and they don't need as much support. And then something might happen, as happens in all of our lives, where we need a little bit more support to get through that. So services are not time limited and should be available throughout the duration of a tenancy. And then finally, just highlighting again that in the beginning of residency or tenancy, the services do tend to be a little bit more frequent and intensive, because you're building that relationship. And like we talked about earlier, it's a really, really critical transition from being unsheltered or homeless going into housing. Back to you, Em.
Okay, so the next component we wanted to address is about coordination among key partners. And this is also key with supportive housing. So the goal is that the primary service provider will facilitate tenants' connection to resources and supportive services in the community, and that the provider, and ideally the provider also would have that housing navigation component that we mentioned earlier, that the provider establishes linkages to medical, behavioral health, employment, and benefit services for their tenant as needed. And so have some notes about this, and just wanted to mention also that the primary service provider would particularly bring connections to resources about behavioral health, primary health care, substance use treatment, and employment. And this is soon after housing entry that the staff would assist tenants with applying to these benefits, including public benefits. And then tenants, would have the right to have a behavioral health care provider, including a psychiatrist, also being connected to the healthcare protection practitioner, and so on and so forth, kind of the realm of services that a tenant would have access to. And that's, again, depending on their individualized needs, because this program encourages a model that's unique to the tenant. I'm going to move to the next slide. So another part that we kind of touched on earlier is that we want to make sure that tenants are connecting with their community. We don't want it to be a institutionalized feel, even if there is an entire building that's dedicated to this population that is what we call a congregate site. Even if the entire site is with PSH tenants, we still wouldn't, the ideal model wouldn't be that they are feeling institutionalized. The hope would be that they are ingrained in the community, and that they're bringing their life experiences into the community as well, and that they don't feel othered, and that their community doesn't feel uncomfortable by that presence or building in their area. And so we encourage providers, and we are encouraging policymakers too, to have units, both both congregate site, which I mentioned, and then scatter site, which we'll go over both of these in a few slides. We want to make sure that these units are located within neighborhoods that have transportation, that have employment opportunities, health services, definitely social services, and also shopping, recreation, parks, plazas, and socialization opportunities. And it would be also up to the service staff to support these tenants with connection to community activities and peers, community members, and family. There are different benefits to scattered sites and then also to congregate sites. But if they were in a congregate site setting, we would definitely encourage that the building has community activities throughout the week, that they maybe like bingo or art classes, writing classes, and whatnot. And then I am going with that. We'll pass it back to Lauren to talk more about congregate and scatter site.
Before you do, may I ask a question? So I'm thinking, like in the program, one of the cardinal rules where we tell the client, you come into the program and you can't afford it to get involved in anger, hostility, fights, and sell drugs, take drugs and stuff, right? And those are grounds for dismissal. So I'm not using the word mandate based on what it is you were saying before. We can't force anyone to engage. So then I would like to use the word creative in the sense, here it is, we know then that houses are very hard to find, to come by. And we have, you are in a supportive group where we try and locate housing for you, but it comes with some contingencies. You have to comply. You can't use this or do that in order to maintain or to obtain housing, as opposed to saying, well, like if you don't do this, then you can't do that. I wouldn't use that. I would say come up with some creative strategies, because since it's hard to come by, since you need it, since it's going to be a problem, you have to engage in the supportive services in order for you to maintain stability. Because if we left it up to you, that might, potentially for some could take care of that, but some, they need the guidance and they need the support, but they just don't want to engage. So I would say then that in order for you to obtain this, then the services that we have, you have to be participating in the services as well to maintain this. And it's a win-win situation, because it's get to help and raise your self-esteem to make it become more productive in society. That was just a thought of mine. I just wanted to share.
Yeah, thank you for that. I would say a couple of things that you brought up that I wanted to touch on. You said, made mention that if folks are like fighting or using, substances or drugs, that is not necessarily a reason for dismissal immediately, right? We wouldn't kick somebody out of a supportive housing program or their housing or end their subsidy just because they relapsed or are using substances. We would support them through. So we would work to support them through that. And try to build insight again about how this could potentially impact their housing. And we're not trying to shield folks from natural consequences of behaviors. And I mentioned earlier, we're not trying to create an alternate reality, but we are trying to help build insight with folks and recognize that they do need that added support, right? And that service connection. And then as far as saying, you won't be successful if you don't engage in services to folks, I think it's really important to highlight the benefits and the best different ways that we can help folks through services, that it's not a one-size-fits-all type of thing. But I think if we're mandating services, it really changes the relationship, and it really changes our ability to help folks become more self-directed and increase self-sufficiency if we're saying, like, this is what you have to do, or even this is what I want you to do, right?
Well,
so I think some of those community connections that Emma was
Mhm.
talking about in the previous slide, those are really fantastic ways to start building a relationship with somebody before you kind of like dive into that more like case management-y relationship. So I think that folks are often coming in, they've often had negative experiences with these kind of like services relationships before, and they might be very
Mhm.
wary of engaging or kind of like, is this like tit for tat,
Gotcha.
So some of the community engagement can be a really fantastic way to say like, hey, I can help you meet this need. We don't have to talk about your substance use right now. We don't have to talk about
Exactly.
your mental health right now, but like, I just
Okay.
want to engage with you. And then
Okay.
from there, it typically develops to, a stronger relationship.
Point taken. Thank you for sharing that.
So, alrighty, we talked about that there are two basic types of supportive housing models. So we've got project-based or congregate, you might hear, and that's typically buildings that have like 40% or more of units that are designated for supportive housing. And then the remaining units are typically just affordable or available to the wider community. These buildings usually have on-site case management, oftentimes a community center. We've seen projects that have things like a medical clinic or something like that built, embedded into the building. And then you typically don't see sites that are like 100% supportive housing, but if it's a smaller project, then it could be. So if it was something like 10, 15 units, could be 100% supportive housing. If it's like 106 units, it's typically about 40% of those units would be supportive housing. And want to also like emphasize that congregate housing doesn't mean shared housing. It just means that the units are located in the same building. So it's not like a shelter type or setting or congregate in that way. And then we also have tenant-based or scattered site models, and that typically just utilizes vouchers to rent units in the private landlord market. And then the case managers would, actively go out and visit folks in their homes and communities and connect them to the community-based services that are available to them in that area. All right, next slide. So financing supportive housing can be super complicated. There's typically, 3 branches that we think of with the financing needs. That's capital and the money to kind of like get the building off of the ground and get those units built. There's operating costs, which include rent and utilities and also the maintenance of the buildings and sites and units. And then the cost of services. So paying for those case management services and being able to have that as a really robust offering as well. So noted here, putting together the financing for a housing project, it's often like that 3-legged stool, right? So we've got capital, operating, services, or like the main components. And it would be super fantastic if there was like one funding stream for each of those things. But typically it's a multitude of different funding sources that are coming together and being braided together to support each leg of that stool. Next slide.
Okay, and this is the Q&A break for this section. We have questions for you all if there's time to, but I do see that Drew, you said something in the chat about maybe having a question, and then Trish just had another question in the chat. So feel free to voice those now if you would like, Drew.
Good morning, everyone. My name is Drew. I'm actually one of the vocational counselors at Montefiore Medical Center for one of their outpatient substance abuse clinics. Even though I am the vocational counselor, I still come across more housing issues than employment or education opportunities, but they go hand in hand. How can you expect someone to go to school or get a job and housing is a major barrier? So my question is, I have a lot of patients that MICA patients, so patients that have mental illness and substance abuse issues. A lot of them live in the shelter system and they feel like the housing specialist / case manager is not being proficient and assisting them with finding housing. I have a lot of patients that have 2010 E vouchers and they don't even know the basics of it. They don't have a copy of their voucher. They don't have a copy of their 2010E package, and they have no idea what type of housing they're eligible for, and who can they speak to as far as in regards to their rights with assistance in finding housing. I usually recommend for them to speak to the supervisor of the case manager / housing specialist. But when that doesn't work, just who can they speak to when they are having issues in the shelter? And is there any agencies that advocate for people that are in the shelter system? And when it comes to receiving assistance in processing their housing vouchers and helping them get assistance in this area.
Yeah, that is, so I know that I've even just gotten like random emails from folks that, will say, I'm living in a shelter. I have no idea what's going on. I don't know what I'm eligible for. I don't know what my case manager is doing. And then in those instances, we do, I'll reach out and see what I can figure out and what I can track down for folks. Mobilization for Justice is another group. Are you familiar with them?
Yeah, and I've also contacted CUCS as well.
Yes.
It hasn't been too helpful, but I can reach out to them. I have so many patients that are having issues with the case manager / housing specialist. Sometimes it is the patient as well, but in certain situations, I don't think it's the patient. I think what it is, maybe they have too large of a workload, like caseload, or maybe there's not enough staff on site in the shelter. I'm not sure, but I
think both of those things are true.
Yeah, I have patients that have been in the MICA shelters for like 2-3 years and said no one has even approached them about getting a voucher. And I'm just shocked, because that's very long to be in a shelter for years and not even discuss housing vouchers. So they know they don't have a subsidy yet. Like, they haven't even discussed that option. I've had patients tell me that the case managers would tell them, you have to not be using any illicit substances at this time, that they have to provide clean toxicology reports. Wow. I don't know how.
In order to get housing?
Yes, that it is recommended prior to them working on their housing voucher. And I don't know how truthful they're being with the patient. So I just wanted to know who maybe I can refer, or what agency advocates for patients in these situations.
Yeah, so my two suggestions were going to be CUCS and Mobilization for Justice. I do know I've been contacted by attorneys from Mobilization for Justice that they'll reach out on somebody's behalf and say, hey, we're having this issue, can you help? It does seem like the squeaky wheels get the oil, right? Right. And I think that what you said too hits the nail on the head, that folks are understaffed and overloaded with their caseloads. I'm trying to think of something immediately that like might be a bit more helpful, or somebody that you could contact immediately. I would say, like, if there are specific challenges and stuff, feel free to reach out to me and I'll look through it and see, what I can do or who I can connect folks with. Yeah, and then after this session, we'll provide like a learner guide and information, like with the slides and all of that stuff too. And I'll try to include resources in that as well.
Thank you.
Yeah, thanks for your question. Jeremy?
Hi, good morning, everyone. My name is Guilherme, and I'm one of the peer specialists at Montefiore Medical Center, one of our outpatient clinics. And a lot of the challenges, well, first off, thank you for this informative guide. I think what's happening is that there's not enough training. And so we aren't aware. And I say we, myself included. I feel like I'm swimming in an ocean trying to find some sort of protocol, some sort of guidance, tangible guidance to let me know step by step how to assist someone. All of the issues that have been brought up, I've already experienced with many of our patients. So I hear a lot of things. So there's the 2010E application, is completed, if you meet criteria, and then whoever is working on that has a list or a guide of housing agencies that they connect with to look for units that are available for them. And it is very clear that shared units are more accessible than independent units. And if someone is interested in an independent unit, they will be waiting on that list for a very long time. That is the reality of it, because they're not there. They're not accessible. That's with the 2010E application. I've not heard that someone has a 2010E application and it's a voucher and they're off on their own to figure that out. Maybe their case manager didn't follow up, but from my understanding, the case manager who's working on it follows through with that, with the resources that they have, with the housing agencies that they're working with. The city FEPS voucher, that is a voucher that I've seen many, many times, and the person, client, patient, is left on their own to find apartments on their own. The housing specialist can provide them a list of real estate agencies that will work with someone. Because I've seen it too. So I've seen case managers that have provided people the resources that they need to continue to do the footwork. I've also went in person with patients to the Brooklyn Peer Advocacy Center and the Bronx Peer Advocacy Center, which focuses on assisting people with the 2010E applications. There are also agencies like Catholic Charities and Volunteers of America that do provide assistance with the 2010E application. However, in those agencies, I've learned that you have to be part of their program.
Yes.
In order to get connected to a housing specialist. But the Brooklyn Peer Advocacy Center and the Bronx Peer Advocacy Center, it's not an outpatient model. It is a resource center of working peers that have been certified and have the access to the CAP system that can help someone complete that application. However, what I've noticed is that there's not enough training and understanding of what to do. And so I, in particular, would love a resource list of who to call and how to navigate the system, because I can easily escort someone to the Bronx Peer Advocacy Center. I can easily contact their case manager and their psych and, get the biopsychosocial done and everything, and at the application and fill it out with them. And, the clinician signs it off. I take it back to the Peer Advocacy Center. They do the intake. And then from that point on, they're the ones that connect with the housing agencies. I'm looking for a resource list of where the 2010E application, where can someone get connected to get assisted filling it out. I've also contacted CUCS, and they bounce me back to, you have to find an agency that does the actual application with them. And then they contact us.
Yeah, and then it's like this ping pong back and forth.
Yes.
Yeah. So these are all, I'm taking notes as we're talking as well, because I think a lot of this is really relevant to the training on Thursday as well, with the access. So I will both work on trying to get some resources together for folks, and then also kind of passing these questions and this conversation on to, well, actually I'll be on the training Thursday and my colleague Patricia, so that we can go into this a little bit more as well. On Thursday, as it relates to the access and navigating those systems. Does that sound okay?
Sure, of course. No,
Okay.
if I may
Well, I'm
interject.
sorry. I know Michael has had his hand up for a minute, so I just wanted to give Michael an opportunity. Are you there, Michael?
Thanks for the individual who spoke. I forgot their name, so please forgive me, with the information regarding the Bronx Peer Advocacy Center that can help with 2010E. When I was hearing the discussion, there are a number of clients that we interact with legal aid that are clients where we speak to them, and when they get the voucher, they feel like they're on their own. Like, here, you get the voucher, here you go and try to find locations, and then we're trying to scramble. I know there was an incident where I had to speak to a supervisor to get the ball moving in terms of trying to get them a list of possible applications. Otherwise, on their own, it just left the, you figure it out. And that's the,
Yeah.
out of the criminal justice system, is like the problem issue. I'm glad we're going to talk about it Thursday about navigating through those systems. And that's where I'll leave the, more questions regarding that, but I just want to know there is a pattern of getting the voucher and not knowing where to go, or getting frustrated because the landlords are rejecting the voucher for some reason, not knowing and trying to go back to their case manager. And the case manager is like, what do you, is pretty much with their not knowing what to do, or just say, just go back out there, just keep trying. And they might not have the capacity, or it's like, you know what, forget it. How do you put that?
Yeah.
For us, we don't have that capacity to work with them ongoing. So we're looking for partners, like who can they go to assist them within that process, and trying to connect them with supportive housing.
Yeah, so CSH is working over the next couple of years. We've gotten funding to support work with the Department of Corrections, with Health and Hospitals, and with ACS, so that we can examine kind of like what the supportive housing need is within those subpopulations, recognizing that, there's a lot of crossover. And also that, kind of the most vulnerable folks are going to be touching multiple systems. So we'll be, working over the next couple of years to provide training, education. I heard that was a gap too, about supportive housing, about the access, and trying to really do what we can to help build up the landscape so that there is more information out there, that folks do feel more prepared, both workers, and then, it also sounds like there's just a huge need of making sure that we're not gatekeeping resources for folks as well. And that if they are in a situation where they're, kind of being put out there, like, okay, you got your voucher, go find housing, that we're able to communicate with them as well, like what those resources are. Not abdicating responsibility, on the behalf of staff and case managers and things like that, but also just kind of trying to do a deeper dive into how we can make the information more accessible to kind of like all parties. Okay, so we have quite a bit more content to go. So I want to keep us moving a little bit. And again, I'll provide like my email address and stuff at the end of this. Or actually, I'll just type it in right now. So if there are any kind of like unanswered questions, please feel free to reach out. And again, I've been taking notes. So when we come together again on Thursday, we'll hopefully have a little bit more answers for you. And then when we send out the content after Thursday, we'll include resources and some more information. All right. So kind of moving along a bit, we're going to talk specifically about supportive housing, for justice impacted populations. So you can go to the next couple of slides, Emma, please. Thank you. All righty. So, noting that every year, about 600,000 people return to their communities from prison or carceral systems and face really like a myriad of challenges, primary being like housing insecurities. So we know, obviously, we've talked about the fact that there's a lack of affordable housing, and, for having a criminal record really just compounds this problem for folks by limiting their options, and a lack of stable housing and affordable housing and a safe place to stay really, furthers justice involvement and incarceration. There's a higher likelihood that people are going to end up back in a carceral setting, higher likelihood that folks are going to, violate probation and things like that, because their basic needs aren't being met, right? And just, knowing that lack of stable housing creates additional barriers to things like accessing food, accessing employment, healthcare, childcare, all of those things. So a few more kind of like points on here, just, formerly incarcerated people are 10 times more likely to be homeless than the general public, which is just mind-boggling. That's a huge increase in rates of homelessness. And we know too that the rates of homelessness are highest for folks that have been incarcerated more than one time, people that are recently released from prison, people of color, and women. And women are actually more likely to be homeless than men, but men are more likely to be experiencing unsheltered homelessness or living outside, or kind of sleeping rough. Next slide.
And we know that supportive housing, and there's lots of research done, reports done, which we'll go through in some of our later slides, but we have seen it is proven that it is a successful, cost-effective, and beneficial model for the population that it addresses. And we have seen that it's successful because it improves housing stability, employment, mental and physical health, and also school attendance for families. It also reduces active substance use. It's been found that people in supportive housing live more stable and productive lives. Additionally, it's cost effective. Which we've talked about, it really does help with the lease and the population that is in supportive housing. And also it's beneficial not just for the tenant, but for the communities, because they are built stronger and healthier, and sometimes even proven to be safer neighborhoods due to these folks being included in the neighborhoods. So we can go through this a bit more if you have more questions. Going to go to the next.
Emma, I would just add a couple of points on that. One, just the benefit to communities. A conversation that we've had recently in New York City is that these folks are coming home to their communities, right? Whether they have shelter or not. So putting them into housing just makes sense, right? Like, so they're going to be in the community. Why not give them a safe and affordable place to be, so that they can be more kind of they can begin the healing process, right? And then with a point that I wanted to make around the cost effectiveness, we recently issued a report around how supportive housing can be used as an intervention for folks that are coming home from Rikers to kind of help break that cycle of people going through carceral systems and then homeless systems and back again. And through that, we found that it costs over $500,000 to house someone at Rikers for 1 year, and that the average length of stay is between like 221 days and 350 days for somebody. So the cost of supportive housing is far less. It is, kind of a rough estimate, I would say like $46,000 a year versus the $500,000 to keep somebody in a carceral setting. So just wanted to raise that. Sorry, go on.
Yeah, well, that's great. We'll dig into that a bit more too in a few slides so you guys can see those numbers. And the next slide is briefly just how it improves health outcomes. We've seen a reduction in healthcare costs overall with tenants in supportive housing. There's an improved access to ambulatory care because, instead of saying we're under this bridge at this cross street, you can say national address with the unit number, which is great. That's just one of the reasons as to why ambulatory care is more accessible, but that's just and then increase adherence to medications because they do have a dedicated case manager that is checking in on them, that is trying to make services with them. And with that comes with accountability to take medication. And just overall improvement in well-being and health for these tenants, and a lot of cost savings for public systems, which we'll dig into more with that Rikers report that Lauren mentioned. I'm going to zoom through a bit quickly. And here's just a lovely quote we wanted to include. You'll see at the end, it says a Fuse housing tenant. We will, in the next slide, tell you what Fuse means. But a housing tenant said, quote, "The only thing missing from my life was a place to call my own. When I got this apartment, I sat in the middle of the floor, my lease in one hand, the keys in the other. I must have read the lease at least 5 times. The next morning I woke up and I was still here. It was a dream come true. And FUSE, that acronym, it is Frequent Utilizers Systems Engagement. So what that means is in 2008, CSH, our organization, initiated a demonstration project testing whether supportive housing with enhanced services can break the cycle of homelessness and incarceration. And this was in 2008, and the population for this program or this study was people with at least 4 incarceration and 4 shelter stays and 5 years. And out of this, we actually saw that the average number of jail admissions was over 11 admissions in the past 5 years with this population, and then they have some behavioral health criteria. So those were the the population criteria, and the program or this what was being studied. So the program offered permanent housing in congregate scatter sites or SRO settings. And the services also include on-site or off-site supportive services through caseworker model. So a bit more info on this is, well, let me back up a second. Lauren, did I miss any details that should be included?
Nope, you're good.
Okay.
Moving.
So this study found that supportive housing can pay for itself as it results in avoided costs. So not only is I guess the study was wondering how much it did cost and if it would cost as much as it costs to incarcerate, provide care in hospitals and to shelter these folks. And we found not only does it not meet that, but therefore it results in avoided costs from these systems. So the study, which included, as I mentioned in this other slide, it included medical care services and permanent housing lease. And all of that cost $23,290, including $14,000 in wraparound services. And so overall, the FUSE participants had less spending on jails and shelters, about $8,000 less, and then also $7,000 less in medical, mental health, and addiction services cost. And so you can see in this graphic that per person, there was 15,000.6 or almost 0.7 less per person in the FUSE on those costs I just said. And the cost avoidances therefore virtually offset the entire cost of the wraparound services. And this just shows how much money, the graphic shows how much money is spent on crisis healthcare systems versus jail days versus shelter days. If we have questions about this slides, I'll be happy to go back to them. I'm just going to zip through though for now. And since 2008, there have been replications of this FUSE study focusing on justice involved population, health population, and then also crossover with justice involved in health. And at the bottom, you'll see a website with our CSH FUSE study, and it's a great website and resource. You can dig into this, and there's like interactive maps and whatnot that you can click on with these circles, which is fun to see. And this just shows the areas of where these studies have taken place so far. Another FUSE model we wanted to mention was Multnomah County. The highlights of the study, well, sorry, one second, look at my notes really fast. Just some background on Multnomah. It's in the greater Portland, Oregon area. And the study included 1,100 more or less chronically homeless adults, and about 200 were given the same stuff I mentioned, and then there was a control group of 800 that remained unhoused to compare what the results were of the folks that were housed and received the services versus the control group. And the highlights of the study, looking at the bottom here, there was over 17,000 less ED visits. There were 5,000 fewer avoidable ED visits. There were 200 fewer hospitalizations. There were 400 fewer jail bookings and 50 fewer inpatient psychiatric stays with this housing and services model. And in Multnomah County, they found that they would be saving $10.2 million housing this population and providing services, so supportive housing, and that those savings could actually be realized with Medicaid, which is super interesting. And again, this is also on our website, that link that was stated, so you can dig in some more. Now passing it to Lauren.
We're running real short on time. We've only got about 10 minutes left. So I think I'm going to try and just take us pretty quickly through the rest of our slides here. Again, we'll send this information out to you, but we wanted to also highlight a project in Denver that was done through a social impact bond, and essentially was very aligned with the Fuse initiative. It was championed by their Mayor Hancock, and provided like really barrier-free housing first, supportive housing for folks. And it was launched in 2016, and they've housed over 365 people now. So Emma, next slide, please. Of those folks, about 86% after year one were still housed, and after year three, 77% were still housed. So this is a really great retention rate specifically for this population. Again, we saw reductions in police interaction, reduction in number of arrests, and a reduction in the number of days spent in jail for this population. And there was a 65% reduction in use of detox services compared to the control group that was not getting this intervention of supportive housing. So we've talked about a number of the barriers that come up with regard to accessing supportive housing. So, we know that getting a good psych eval can be really challenging. It can be hard to look over, charges that folks are facing. Document readiness is another huge thing that we see with folks that holds up their ability to get into housing. Another really critical point is that time in prison or jail or other carceral or institutional settings does not count as homeless time. And in addition to that, it can actually count against folks. So in order to qualify for supportive housing, you've got to meet the definition of chronically homeless, which essentially means folks have experienced 12 or more months of unsheltered homelessness, either consecutively or in a period of about 3 years. Oh, go ahead. No, okay. So it's a pretty hefty definition to meet in the first place. However, once you've spent 90 days in a institutionalized or carceral setting, that clock starts over. So essentially we could have somebody that's got 12 years of homelessness documented under their belt, and they go into jail for 91 days. Their clock starts over and they're released from jail, and they have to build up all of that chronicity over again. So that's a real huge challenge that we're working we're advocating for time spent in carceral settings to count towards homelessness. And then also just a misunderstanding on the part of the resident of what supportive housing is. A lot of folks think it's another institutionalized setting, and there's a misunderstanding there. And then there's also misunderstandings with how to access the housing and to sort through all of the challenges that we talked through earlier of low staff and high caseloads. Next slide. All right, so I'm going to skip through the next discussion question because it was around what barriers are coming up, and I think that we've kind of covered that today. And we'll talk a little bit about where we see supportive housing in New York City. Next slide. So it's really important that we highlight and point out the racial disparities in the homeless system and other crisis systems in New York. We put out a tool in early 2020 that looked at the crisis systems that often refer folks into supportive housing. So those kind of like feeder systems. And most other indices that we see use white populations as the baseline or comparison group for all other racial or ethnic groups. i.e. like looking at Black rates versus white rates, Native American rates versus white rates. And our index compares each group to the aggregation of all other groups. So kind of looking at a really like holistic picture of what we're seeing. And it decenters, in effect, whiteness as the standard from which all other groups are measured. So this can be viewed as like a likelihood of one group experiencing an event compared to the likelihood of another group experiencing that same event. So the info on the slides is New York, and the tool did look at all 50 states. It's interactive, and you can actually download the data and use it yourself. And we'll share a link to that when we send out materials afterwards. But just noting, not really to anyone's shock, that there are significant racial disparities for BIPOC populations across multiple systems in New York. And that's due to historic and systemic racism and marginalization. BIPOC are overrepresented in crisis and institutional systems like the homeless and justice systems, yet underrepresented in the areas that provide the social benefits to vulnerable populations, including the mental health system. And really, seeing a lot of this brought to light. A lot of us have known this for a long time, but especially COVID-19 really shone a light on these disparities as communities of color really experience higher rates of infection and death as a result of the same virus. And then just to note that data really is critical for advancing racial equity through public policy and practice. Existing racial and ethnic trends, disparities, and inequities need to be tracked. And we need to track this and document this and share this out transparently in order for communities and governments to be accountable in transforming systems that foster really equitable and inclusive communities. Next slide. So wanted to talk a bit about JISH, which is Justice Involved Supportive Housing. So it's housing that is targeted for folks that have experience with the criminal legal system. Currently, our city only has 120 beds. And through our Rikers report, we estimated that the need is actually closer to like 2,500 that folks, in any given year, about 2,500 folks that are in Rikers would benefit from supportive housing upon their discharge. So there are a lot of challenges tied to this, not least among them the fact that the current JISH rates for reimbursement for the housing subsidies and services are not in line with the costs that we're seeing. So that's a real challenge. And as part of the effort to close Rikers, we're recommending that we raise the number of JISH beds to 500 so that there's more beds specifically designed for this population so that folks can kind of go right from incarceration into housing when they're discharged. But also that we look at the eligibility criteria. While there is that gap in time experience, homelessness experience before incarceration versus that clock kind of getting wiped clean afterwards, we're looking at ways in which we can make recommendations on eligibility criteria so that folks coming out of incarceration and have that kind of that slate wiped clean are not held to the same exact chronicity standards, or that their time incarcerated, like I said earlier, can be counted as time homeless. Next slide. I'm gonna buzz through the next couple of slides because we talked about the report. We'll include a link to that. On the next slide, we talked about the cost impacts. And then if you go to the next slide, Emma, some key actions that came out of this report that we would like to see happen is there needs to be a real significant investment in supportive housing. We really need to consider how we can improve access to supportive housing, and we need to develop the data and report out on it in a way that's really transparent and timely. so that we can really examine what the need is, and how we can work to meet it in the city. And keep going. Thanks. Again, just, some of the barriers to developing and accessing supportive housing we'll go into again on Thursday, but some of them are listed here. And then last slide. Because of its success, New York has dedicated funding streams for several years for supportive housing. So you can see here detailed up on the right-hand side of the screen, that starting back in 1990 and going all through today, we've had various different initiatives to make sure that we've got dedicated funding streams to support supportive housing and the services and subsidies that need to go along with it in order to make us successful. And New York City is, I've worked in supportive housing communities all over the country, and New York City is very, very different in the way that they prioritize the funding for supportive housing. And now, we just need to get it together around access. Alrighty, so we are right at time, and apologize for going over a bit. But if there are any questions, we can take them now.
I did want to bring up, I'm not sure if Trish is still on, but Trish had a question regarding the supportive housing type. For our participants in the legal system, some are triggered or just don't want shared space. Wondering what % of NYCSH are independent versus shared living spaces? And are candidates allowed to select this as a preference?
Yeah, so Trish, I did actually note your question, and I don't have ready the comparison of what percentage is shared housing versus folks that have independent units, but I'm going to try to find that for you and report back. Candidates are allowed to say that they don't want shared housing options. One challenge, like I mentioned, with the JISH rates being so not up to date, I think the subsidy rates for the JISH housing is stuck at a 2017 fair market rate. And what we're seeing is that in order to be able to house folks, they're having to combine vouchers and put 2 vouchers essentially on 1 unit. And then folks are having roommates oftentimes that they don't know. And this is really not ideal for anybody to, kind of be forced into a situation where they're living with strangers, but particularly we see it as challenging for folks that are coming out of incarceration. So we are also advocating that RFP for the additional JISH units include an increased rate so that they can have proper subsidies to get folks their own apartments.
Thank you.
Yeah, and typically if someone, it also can just mean that they're on the waiting list for longer if they want an individual space. As you can imagine, shared spaces maybe come up quicker than independent, but we're trying, I think most construction is geared toward individualized spaces. How you did me?
Hi, everyone. I just wanted to piggyback off that question, just based off of experience, that one can state that, well, that psychosocial is key. That psych eval is very key, because that the clinician has to show that, 1, you meet the criteria for supportive housing, and 2, that you also are capable to live alone. And that piece of paper is imperative, because it's when it gets sent to see if the person is even eligible for it, for that kind of level of housing. That's going to give the determination. I just recently had an experience with someone that I escorted him to one of the advocacy centers. We put in the application, did the intake, but he was denied because his psychosocial wasn't up to par. And so we had to do it again. And he's looking for independent. And I'm very honest with them. I said, you're going to wait for a very long time. And if you limit yourself when you choose, for example, I just want to be in the Bronx. I don't want to go to Manhattan. You have, one has to also speak to their patients or the clients, let them know the reality of it. And make a a decision that is best based on their needs at that moment.
Yeah, you're right. Thank you for continuing to like highlight your experience and expertise in this arena as well. Appreciate hearing from you, from everybody. This has been a really participatory group, which we appreciate.
Lauren and Emma, we want to thank you so much for taking your time, and everyone here who is made the time to attend. Please share with your colleagues, because I think the next session is going to be super important.
Yes.
For actually being able to connect each and every individual to these housing services. So we appreciate your participation, and we appreciate you, Emma and Lauren. Thanks so much.
Thank you. Thanks for holding this space and being with us this morning.
Thanks,
Thank you.
guys.
Yeah, the Thursday sessions at the same time, 9:30 to 11. Look forward to seeing you there.
See you.
Bye, everyone.